All
Let's
right.
start. I can't see your screen yet, Keith.
It's there.
Oh yeah,
Should
yeah.
be.
Now I do. Now I do. Okay, never mind.
Yeah, good.
Periodic
Okay.
analgesia. Go.
Okay, this will be a fairly brief talk. Should be done by 8:30. Reasons are twofold. One is I have a migraine headache coming on, and I think I might have to get and lie down fairly soon. And the other is that I'm traveling tomorrow, so I need to be up early in the morning. So some fairly straightforward, simple stuff on the subject of peri-operative analgesia. And the reason I've got this subject is really because of trying to emphasize the impact that what we do intraoperatively can have on the post-operative course. Very important to note that what we do intraoperatively makes a difference to what happens post-operatively. First of all, it's worth knowing what is pain. It's a physical sensation. When you have a painful stimulus, it hurts. It's also an emotional sensation. You don't like it. It's not good. There's some very good evidence that pain, inadequately controlled pain, is a serious obstacle to healing, not least because it prolongs hospital stay. Patients who do not have adequate analgesia and have high pain scores have on average a 1 to 2 day longer hospital stay than those that have lower pain scores, whose pain is adequately managed. It also incidentally contributes to prolonged or a greater incidence of post-operative chronic pain syndromes. Good link has been established in a number of areas between the intraoperative pain control and the post-operative pain control and the emergence of later chronic pain syndromes. There's a sort of formal international definition of pain from the International Association for the Study of Pain, which is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. I don't know how many years it took them to arrive at that definition, but it does seem quite a good one. More practically, however, and especially in the ward context, pain is whatever the patient says hurts. Just a quick look at some of the neurology of pain. The pain stimulus obviously comes in through the dorsal root ganglion and is transmitted upwards into the brain where it is perceived. Some of the stimulus goes straight up, and that's the discriminative pain. Let me just get up a reference here because I need to actually look at this. If I don't look at it, I will be unable to tell you all the detail because it's one of those things I do not carry easily in my head. Okay, give me a second to come back to it, and we seem to have a problem. Yeah, there we go. And so the spinothalamic tract transmits information about temperature and pain as well as simple touch. But the different elements of the pain stimulus, the discriminative ones, the ones that tell you where the pain comes from, and any arousal emotional components of these are separated out. And there's a fast discriminative aspect and slow affective aspect. If you think about it, when you touch a kettle, it feels hot and it hurts. But actually, you withdraw your hand before you notice the pain. And that's the difference between the fast one that tells you you've got a problem and where it is and gets you to react to it, and the slow one which tells you what you feel about it. Discriminative pain reaches the thalamus directly, whereas arousal and emotional pain reaches the thalamus indirectly via connections with brainstem areas such as this one here. Slow pain, however, that is the more chronic forms, the more sort of agonizing pain, the one that is more consistent and is the result of continuing tissue injury is transmitted by other pathways, such as the spino-reticular tract. So that pain pathways, we can say, are very complex and are designed, as it were, for different purposes. The immediate discriminative to enable you to react quickly and remove yourself from the pain. The more slower emotional aspect that says, that hurts. And the longer term slow transmission via the spino-reticular tract, which says, that is continuing to hurt. I do not like it, and it is going to be a nuisance that I need to deal with. At some point in that process, however, the spinal column starts to react and say, we don't like this, we're going to block it. And it starts to get a situation where the stimulus is coming in and the spinal column says, we've got to wind this up. You get a phenomenon called spinal wind up, where the pain perception is altered even though the pain stimulus is the same. We're not actually concerned with chronic pain today, but I just wanted to emphasize that there is a lot of stuff in the pain experience that connects the issues of immediate pain to the chronic pain syndromes that you see later. And the interaction of all the stimuli within the spinal column is probably the common pathway in all of that. Okay, let's go back to a bit more basic principles about what we're doing with an anesthetic. Goodell's stages of ether anesthesia, which were derived just from getting a patient to breathe ether until they were deeper and deeper and deeper, showed basically these 4 stages of anesthesia. Ether is a weak anesthetic, so you went through all these stages in visible and recordable terms. In order to carry out abdominal surgery, you needed the patient very well relaxed. So you wanted surgical anesthesia, stage 3, but at levels of 3 or 4, which were pretty close to respiratory paralysis. So what we've done since is to add in muscle relaxants, which enables you to keep the patient anesthetized at levels of surgical plane 3 without any need to go that much deeper. But these are the stages of anesthesia, which if you simply use an anesthetic, are the stages you go through. Safe anesthesia is probably carried out at surgical anesthesia at stage 3, plane 1 or early plane 2. And that is achieved nowadays by the triad of anesthesia, where we combine agents which give us sleep with agents that give us relaxation, and we supplement both by agents that produce pain relief. And you'll see why I've gone into this in some detail in a moment. We've only really got two types of agent for sleep. One is an intravenous agent, mainly propofol, though others are used, such as thiopentone, and inhalation agents, such as sevoflurane, isoflurane, and some of the others we know about. Those are really, we only use one at a time, effectively. There's no way we can use more than one at any stage. Likewise, with the muscle relaxants. It either relaxes the muscles or it doesn't. So we tend to use atracurium or rocuronium or vecuronium and achieve that particular leg of the triad in that particular one-off way. When we come to pain relief, though, we've got many, many ways of doing that. We can use opiate drugs, morphine, fentanyl, alfentanil, remifentanil. We tend to prefer to use those in the short-acting form, so they don't so much influence whether the patient will come round quickly or not at the end. Their sharp onset of action means you can deal with the fairly sharp stimulus of surgery even in patients who will not have much ongoing pain, such as those having, say, a small lesion taken off the skin. We also use non-steroidal drugs, though these are fairly recent and they don't seem to have much place in anesthesia, but they do have a place in post-operative pain relief. More about how we can use them more effectively in anesthesia later. Lignocaine and other drugs that have actions in and around the sympathetic nervous system are becoming fashionable, and we'll go into more of that later. We make a lot of use in anesthesia of regional blocks, and it's important to use those. We tend to use them as an alternative to general anesthesia, much less often as an adjunct to general anesthesia. We as anaesthetists don't, on the whole, tend to use local anesthetics, but the surgeon can, and I believe, as I'll say later, should. Important to remember, though, and I think this is now a growing science, that we can use all those drugs that we've just talked about much more readily and much more actively, in the sense of producing an approach that enables us to combine the best effects of opiates, non-steroidal drugs, other non-opiate adjuncts to anesthesia, such as lignocaine and clonidine, and regional blocks and local anesthesia. We can use them together in what I think ought to be known as multimodal analgesia. The benefit of doing it that way is that not only can you deal with the needs of surgery, you can also prepare the patient for much better quality of pain relief post-operatively. What do we need in the middle of the operation? What do we actually need? We need sleep. We do need other things to accompany that, particularly relaxation, so the surgeon can have a good operative field and get to do what he needs to do, or she. We need hemodynamic stability, which is something that isn't in the triad, but is a pretty important component of good anesthesia. And we need the patient to lie still, which is usually achieved either by deepish anesthesia or by relaxation, or a combination of the two. The beauty of the opioids is that they enhance and prolong the action of the hypnotics, because they have a sedative effect, and they do inhibit breathing. So in anything other than body cavity surgery, very often we don't so much need relaxant if we're giving high-dose opioids. They do also enable us to keep stable hemodynamics, and as I've said, they inhibit breathing. So there was a long period when we thought, particularly for major surgery, we needed opioid analgesics. And in that triad I showed you earlier, we made them the third cornerstone of anesthesia. When we said analgesia, we tended to mean opiates, opioid drugs, morphine, fentanyl, remifentanil, alfentanil. We tended to equate them with good anesthesia. Okay. There are problems, however, with the opiates. Not only do they produce side effects that we know about, but they also have an inhibitory effect on post-operative analgesia. This is a study in which the threshold of which pain is perceived by withdrawal of a foot in animals after a bolus dose of fentanyl as against a placebo. When the fentanyl is given, obviously the pressure threshold diminishes markedly and returns to normal after a period of time. But in these particular experiments, they showed that for a while afterwards, and it may be as much as 2 or 3 days afterwards, the threshold to which they responded was lower than in the placebo group. So in other words, these patients had responded to a short administration of fentanyl by developing hyperalgesia. And that's known not only for fentanyl, but in a clinical setting for remifentanil infusions too. I used to use remifentanil infusions quite a lot, but since that evidence has become available, I now use them much less often. And I use them essentially for operations that are stimulating, but where the level of post-operative pain relief needed is very, very low indeed. And that's usually cosmetic surgery, such as facelifts. I rarely now use it at all for anything more substantial than that, for that very reason, that they do generate quite considerable hyperalgesia post-operatively, increasing the pain relief requirement in the post-operative period. There's also some work showing that if you allow acute pain to persist, that does lead to chronic pain. Here is a group of patients having hernia repair, groin hernia repair, inguinal hernia, and it's shown that they have perceived residual pain 1 year after elective day case open hernia repair under local anesthesia. And with 500 patients, they managed to get 466 adults, and they compared data obtained at 1 week and 4 weeks after surgery with data taken 1 year after surgery. And a certain number of patients had died, but 19% had some pain a year after surgery. 6% had moderate or severe pain, 6% had restricted daily function, and they found out from comparing that with early post-operative pain scores that there was a much increased risk in patients who had a high pain score in the immediate post-operative period. So, and it's the same also for burn patients. A very sophisticated study from Seattle showing that patients' ability to recover well, their recovery of function, their return to work, was directly related to the way in which their pain was controlled post-operatively or during the acute phase of burn injury. There's also been other studies which show a very similar.
Yes.
Very similar.
Mustafa Khreishi has a question about remifentanil, and Mustafa, if you can unmute your microphone and ask the question, because I don't quite understand. See in the chat box, Keith, he says remifentanil is a good choice in ICU for transfusion. What does this mean, Mustafa? If you don't have a microphone, just type it in. Write it down. Transfusion? I've never heard of.
I think he means infusion.
Infusion. Well, maybe you can answer that question anyway.
I'm not suggesting, Mustafa, that remifentanil is a bad drug. I'm talking about it for only in this context for the treatment of intraoperative response to surgical stimulus and the impact it and other drugs has in the immediate, i.e. first 2 or 3 days post-operative period in increasing the analgesia requirements. I myself like remifentanil in the intensive care situation. I also use it for burns dressing changes, because used on its own as a continuous infusion in those contexts, it actually allows you to have a much more awake and cooperative patient than you would get were you using more conventional techniques with a mixture of a benzodiazepine and say morphine, diamorphine, or alfentanil. The key is that those patients are having longer term infusions or infusions for a specific episode, and this is a different context to the one we're talking about, which is the acute surgical situation. I hope that answers your comment and question. The key thing is that there is a known association between the inability to control pain in the immediate post-operative period and chronic pain syndromes. So not only do we have the problem that some of these drugs cause hyperalgesia and make acute pain control somewhat harder, but they also then, if the pain is not well controlled, go on to lead to chronic pain syndromes in a higher proportion of patients than where pain is well controlled. Now, when it comes to multimodal analgesia, it's important to remember that opiates are still part of the solution. But there are ways of minimizing the problems associated with opiates, and we'll come to that later. Non-steroidal anti-inflammatory drugs certainly have a place, and again, more about that later. Various ways of providing sympathetic block are also gaining traction, because they do enable us to minimize the impact of the secondary mu receptor and thereby minimize the problems associated with opiate use. Regional blocks and local anesthetics are obviously have a place, but more about that later. Opiates have a major effect on physical pain. They're working at the mu receptors in the central nervous system, and that is in the spinal cord and the brain. They also have an impact on the emotional response to pain, and that is the production of euphoria. I remember one chap saying after cardiac surgery, he was an anaesthetist, he said that the pain was just as bad as it would have been without the opiates, but he didn't care. And I think that probably exaggerates but illustrates the impact of the euphoria aspect of the opiate drugs. They do have side effects, hypertension, nausea and vomiting, and they do generate hyperalgesia. Some of the hyperalgesia, in fact all of it probably, is related to the fact that you've got three parts of the mu receptor. You've got the mu, the delta and the kappa. Mu and delta are agonistic, and the kappa receptor is antagonistic. The problem is that the opiates tend to activate the mu receptor, but they also sensitize the kappa receptor. So you get tolerance and you get hyperalgesia in consequence of that. So that it's important to get that relationship. Certain drugs like ketamine block the K receptor, and that I think makes them quite helpful in this context, as we'll see. The non-steroidal agents, such as ibuprofen, produce milder analgesia. They work peripherally by generating antiprostaglandin activity, and they've got relatively few side effects, except in patients, for instance, who have renal failure, or in the elderly, where their action can be prolonged. Their major side effect, of course, is that they cause platelet inhibition, which does increase the risk of post-operative bleeding. And some surgeons will say to you, I don't want that risk, I'd rather we did without them, please. And some patients do get some nausea, vomiting, or other symptoms from them, and therefore don't tolerate them well. But they're quite good complements to opiate analgesia. As we've said, opiates work largely centrally, whereas these work peripherally, largely by diminishing or obtunding the inflammatory response at a local level to the surgery that's taken place, so that they have an anti-inflammatory effect at that level without having, and therefore supplement and complement the action of the opiate drugs. There is good evidence that the analgesics post-operatively do make a difference to the amount of morphine consumed. So if you use the two together, you're going to get a much lower dose of morphine requirement than if you use morphine or other opiates alone. There are a number of non-opiate analgesics we can use. We have in the past, I think, because of this obvious need within surgery to have strong painkillers, and therefore our reliance on the opiate drugs, we've tended to think that the non-opiate drugs are for post-operative use. There is now good evidence that if you start them intraoperatively, then you produce a beneficial effect, not only reducing the amount of opiate analgesic you need intraoperatively, and therefore reduce the side effects of the opiate drugs, but you also enhance the quality of pain relief afterwards by getting on top of some of that peripheral inflammatory response. Low-dose ketamine has the advantage that it does tend to inhibit the stimulation of the K receptor within the morphine receptor. Diclofenac and parecoxib are obviously intravenous drugs that are available, but they can also be given by the rectal route, and they and paracetamol can be given pre-operatively as pre-medication with considerable effect, especially in more minor surgery. Paracetamol is now available intravenously with a gram of paracetamol being roughly equivalent to 10 milligrams of morphine, and about twice as potent as a similar oral dose, and obviously acting more quickly. So these drugs are very useful in starting the process of multimodal analgesia for the post-operative period. Possible also to provide some sympathetic block, which has an impact on the amount of opiate required and on its potency of action. Clonidine has been used for many, many years now for as an adjunct to post-operative analgesia, and is quite a good analgesic on its own in some circumstances. Dexmedetomidine is about 20 times the potency of clonidine and also about 20 times the price. And people have avoided the high cost by using high-dose clonidine, 120 to 150 to 300 micrograms, and perhaps even more in some cases in the intraoperative period. Beta blockers theoretically have a benefit in this context, but their side effects in terms of cardiac output depression probably mean that they're not a lot of use. Indirectly, you can block the sympathetic effects by use of nicardipine, by lignocaine, and by magnesium sulfate. People are strongly advocating lignocaine these days. As much as 30 years ago, there were some Swedish studies showing lignocaine use by infusion as a means of providing sole analgesia for peripheral pain from burns. And those studies showed great benefit. I think it didn't become popular, mainly because most of us are very aware that the therapeutic margin between a useful dose and a toxic dose, particularly on the myocardium, of lignocaine intravenously is not that great. And so we felt that in terms of ward use, it would probably not all that effective. However, people are starting to advocate the use of a single shot of lignocaine in the immediate post-operative period to knock out the peripheral end receptors for pain and thereby enhance the immediate post-operative pain experience, and also to where am I going with that? Can't remember. Doesn't matter. Magnesium sulfate has also been tried in this context to produce some sympathetic block and thereby enhance the action of morphine and other drugs and provide even pain relief peripherally on its own. I don't know much about those because I haven't used those drugs myself, and therefore I can't talk about them from experience, only from reading the literature. But all these are adjuncts to opiate use, or even for milder pain, substitutes for opiate use, and certainly are able to enhance the cardiovascular stability of the patient who is receiving opiate and other drugs. I think also as anaesthetists we haven't given much credence to the use of regional blocks for pain relief, not as much as we should. I think there's been a tendency to think, I mean it certainly was true in burn pain, that if the pain was in an area greater than the area covered by the infusion, that negated the use of these things. Yet there's good evidence now in practice and in studies that using regional blocks, even if they only cover part of the pain experience, can considerably enhance the overall pain experience and reduce the opioid and other analgesia requirements. In terms of limbs, obviously the best way to replace a limb block is using an ultrasound device, particularly for the interscalene area, where you can put the block or blocks precisely close to the nerves as they exit the trunk, exit the vertebral column and become the trunks of the brachial plexus. The femoral nerve, again, best isolated by the ultrasound means, but can also be managed very easily with the nerve stimulator, and likewise the triple block in the hip. Those blocks, particularly the interscalene and the femoral blocks, are very amenable to putting a catheter in and running an infusion for 24 to 48 hours. And that can make the pain, just totally transform the pain experience. Ankle blocks and wrist blocks can provide very good analgesia for up to 12 hours. And for hand or ankle surgery can therefore again totally transform the pain experience. Epidural catheters can enable you to carry out an infusion, which can then work for up to 24, 48 hours as well. Particularly useful in the thoracic route, though I'm not very experienced with thoracic epidurals, for abdominal surgery. The snag with epidurals, of course, is the motor block and the loss of the ability to control bladder and possibly sphincters. And therefore, those are really confined to the non-ambulant patient. But they all maximize the pain relief and minimize the use of nasty opiate drugs. I think local anesthetics are significantly underused. Well worth talking to surgeons you work with regularly, especially when you've become a specialist, and ask them to use them often. Very good evidence in joint replacement surgery, particularly knees, that local infiltration around the wound before closing up and into the joint make a massive difference to the ability to walk, ambulate the next day. In fact, many surgeons have gone away from the practice of using a femoral block as post-operative pain relief to using local and intra-joint analgesia, sometimes even topping up with an intra-joint infusion into any drain that's been inserted before the drain is removed. And that method has proved very successful and is now recommended in the UK by the National Institute for Clinical Excellence as the best way of providing post-operative pain relief in knee replacement surgery. And there are quite a number of other areas where direct use of local anesthetics has proved to be of greater value even than regional block. In terms of any kind of surgery where you're entering through the skin, the injection of bupivacaine or other local anesthetics pre-incision is of great value, both in reducing the opioid requirement during surgery and in providing pain relief. Plastic surgeons do this routinely. The reason they do it is because they are giving adrenaline to minimize bleeding. They don't do it for the pain relief benefit, but the fact that it has that as a side effect is of great value in body surface surgery. Even for things like laparoscopy or hernia repairs or other wounds, any abdominal wound or thoracic wound, the injection of local anesthetic subcutaneously both sides of the wound makes an incredibly high difference to the experience of pain. So that, again, encourage your surgeons to actively use local anesthetics with or without adrenaline, but preferably without unless they want it for blood loss prevention, into the wound after closure. Both sides of the wound, and for things like a hernia, there's a readily available site, just a fan injection on the lateral end of the wound for blocking the ilioingual nerve. So where there is a local nerve block that can be employed, that's very helpful. But local anesthetic into all the wounds from laparoscopy makes a massive difference to ambulation post-surgery. And as I've mentioned, bupivacaine into and around joints following knee replacement and other area surgery. Local anesthetic in and around fingers, in the hand, around the wrist. As surgeons nowadays in the UK very often do local nerve blocks around the wrist and the foot, even if you haven't done them for them. They will very often just routinely do them to provide pain relief post-hand or ankle surgery. There are some good principles to observe in terms of post-operative pain relief. First is that the proper dose of any drug is enough. There is no correct dose, particularly of opiates, but also of other drugs. Most of the other drugs, there's a fairly standard dose that seems to work in most patients, and that's fair enough. Oral route is usually effective, even for morphine. And where it's not, particularly 24 hours post-abdominal surgery, the rectal route is possible, and there are drugs such as paracetamol, as we've mentioned before, that can be very effectively given intravenously and should be used in that context because they're very much opioid sparing. It's often the reason for not giving paracetamol 6-hourly intravenously 24 hours post-abdominal surgery is cost. I'm sorry, but the cost of an extended stay is greater than that, and therefore very important, even in the patient who is not yet able to take oral drugs, to use regular non-steroidals by the intravenous route. I've mentioned the word regular several times. I think there is a lot to be said for a regular dose regimen rather than I'm in pain, doctor, can you give me something for it approach to post-operative analgesia. Regular doses of paracetamol and or diclofenac by whatever route works makes a big difference to the doses of opiate required, and in most bits of surgery opiates are rarely required at all if that regimen is used and used properly, especially as a supplement to surgically applied local anesthetic. Very good benefit for combining analgesics, simply because the dose of each that's required is less than if you use any drug on its own. I now, for a lot of my surgery, write up regular paracetamol, regular diclofenac by the appropriate route, with as and when breakthrough pain relief using oral or intravenous morphine. And I'm actually finding quite often that patients don't actually need any opiate at all in the post-operative period if you use regular dose combined analgesics. Sometimes if you do require an opiate, using a long-acting version such as a slow-release morphine or slow-release oxycodone is a better approach than using giving that regularly in more severe pain, as well as the non-steroidals, is a better approach, again, than trying to treat breakthrough pain. In other words, if you get a lot of breakthrough pain, add a long-acting dose, a small dose of opiate by mouth or by other means. Quite important also to keep tabs on what's happening with post-operative pain. I think it's very important, if you're giving opiate drugs by any means, to actually understand what kind of pain the patient is getting by measuring it before treatment, and then checking whether you've had a good response by measuring it again 1 to 2 hours after treatment. And the commonest way of doing that is the visual analog score, which asks the patient to determine or to tell you by drawing on the line where their pain comes in between no pain at all or worst pain possible. You can do the same thing with children, as long as they can understand words. So down as low as 2 or 3 years old, this particular FACES pain rating score will work, and works quite well. And they just point to the score that means what their pain is giving them in terms of hurting. I think that's all I'm going to do for now. Sorry, it's been a short lecture, but I think that's a quick rattle through multimodal pain relief. The key points I think that I wanted to emphasize were, first of all, that what you do intraoperatively makes a large difference to what happens postoperatively. Inadequate postoperative pain makes a large difference to how the patient recovers and whether they get any chronic pain syndromes later on. So start with the anesthetic and start the postoperative pain control with the anesthetic, using more than one approach to the pain relief that you're giving the patient. And newer drugs such as lignocaine, clonidine, dexmedetomidine, while they are still, I think, the subject of some controversy, will, I think, find a very important place in our armamentarium in the years to come. I hope that's been valuable. As I say, sorry it's been a little short, but I'm going to have to leave you very quickly and get my headache under control. Is that okay?
Yes.